Well, good morning, everybody. Hi, and welcome to Living Well with Diabetes. This is a gorgeous Tuesday morning. If you're in the 518, I hope you've had an opportunity to at least stick your nose outside and enjoy the sunshine. I'm certified health and well-being coach Benita Zahn on behalf of your 1785 healthcare team, powered by CDPHP. Now, before we get started, you're probably wondering, what is 1785? Well, nearly a year ago, CDPHP teamed up with 4 local independent physician specialty practices, and they include Albany ENT and Allergy Services, Albany Gastroenterology Consultants, Capital Cardiology Associates, with whom I'm affiliated, and New York Nephrology. And together, they opened what many have called the doctor's office of the future, and it's located at 1785 Route 9 in Clifton Park. And the amenities are just lovely. They include Connect RX on-site pharmacy, complimentary healthy living cafe, a patient education center, and really so much more. It's just a great place to stop in and check out. Now, the goal of 1785 is to provide the community, that's all of you, with the highest level of patient care combined with a world-class experience. Today, we're introducing you to some of the 1785 physicians, as well as a special guest from community care physicians, all who help patients live well while managing diabetes. Now, before we launch into it all, a couple of housekeeping items of which I'm used to sharing, but they're important. For the privacy of patients on this call, your names will not be visible here on the Zoom and your phone lines are muted. That said, though, all of our presenters are looking forward to interacting with you, so they want you to ask questions. So please, enter your questions in the chat feature below, and we're going to do our best to get to all of them. Some of you have already had questions, so you know that we're here and answering them. Also, as a reminder, for those of you who've registered for more than one session today to hear more of our presenters, each presenter session has a separate Zoom webinar. So at the conclusion of this webinar, you're going to need to exit it and then return to your calendar or email confirmation to find your next session's unique Zoom link. I'm going to be doing the same thing. I'm with you all day. So without further ado, it's my pleasure to introduce you to today's presenter. Number one up in the batter's box here, Dr. Siobhan Kuhar. She joined Albany ENT and Allergy Services in 2005 as a general otolaryngologist, and since then she's earned board certification in the subspecialties of allergy and sleep medicine. So she treats patients with clinical disorders involving the ear, nose, and throat, both medically and surgically, as well as those specifically and specially related to sleep. In fact, she recently spearheaded the introduction of hypoglossal nerve stimulation to treat obstructive sleep apnea in the Capital Region. Dr. Kuhar earned her PhD and medical degree from Albany Medical College, where she completed both her residency and internship. She's a member of the American Board of Otolaryngology, Head and Neck Surgery, the American Academy of Otolaryngology, and American Academy of Sleep Medicine, and the American Academy of Otolaryngology. So please welcome me in joining Dr. Siobhan Kuhar, who will be talking with us today about obstructive sleep apnea. Dr. Kuhar, the floor is yours.
Thank you so much, Benita. I know it is a lovely day out there, and remarkable that everybody was able to get inside to do this. Let's see. Uh-oh. Are you seeing my screen now?
Yes, we see your screen. Yep.
Okay, just opening my.
There you go.
All right. And are we good?
Yeah, looks great.
All right, perfect. I'm just going to minimize that. Okay, so yeah, lovely to be a part of the 1785 community for sure. It's just a wonderful place to work, and you certainly can't miss it. The bright green building facade on the outside. Let's see, we're going to advance here. Okay, now I'm set. Okay, so as Benita had mentioned, I'm part of Albany Anti-Allergy Services, and I'm an ENT surgeon, but definite special interest in sleep medicine, which I've been doing for, gosh, about 18 years now. So today I'd like to share with you some insights regarding just normal sleep physiology, but also the impact of sleep disruption, particularly on diabetes. And we'll talk about sleep apnea in particular, some of the overlapping risk factors, the mechanisms behind sleep apnea's impact on the development of diabetes and the control of blood sugar, and the benefits of treatment of sleep apnea with regard to control of diabetes. So what is sleep? Well, it's a physical and mental resting state. You know, certainly we are relatively inactive and unaware of our environment. There's a partial detachment from the world. The external stimuli are blocked from our senses. Physiologically, we see a decrease in body temperature, blood pressure, breathing rate, but remarkably, the brain actually remains quite active. This is a time in our day when, of course, we dream, we tend to problem solve, we make memories, we consolidate our memories. So it takes up a third of our life, and you know, really is quite a frontier with regard to all of the things that are occurring during that time and the importance of those different functions. Sleep has structure to it. It has cycles that last 90 to 120 minutes, and these cycles are divided into non-REM and REM stages of sleep. The cycles continue throughout the night, and generally we experience about 4 to 5 of these cycles ideally a night, giving us our relative average amount of sleep. So these cycles are divided into non-REM and REM sleep. Of course, the REM sleep is also something that many of us are familiar with as being our dream sleep. And we go through these cycles throughout the course of the night, but you'll see that during the course of the night, the content of the cycle changes, making REM a much larger proportion. This is why by morning time, we're often awakening out of REM or awakening often out of a dream. So all the cycles are not the same, and REM becomes a larger proportion over the course of the night. So what controls our sleep drive? Well, there's 2 main controllers of sleep drive: our homeostatic drive, which is essentially our mental and physical fatigue that we accumulate over the course of the day. Scientists have been looking at different hypnotoxins or the things that accumulate within the brain over the course of our wake that ultimately actually wind up getting kind of flushed out of the brain during sleep. So that's one of the purposes of sleep, is to kind of rid the brain of these toxins that sort of accumulate over the course of the day due to all of the work that's being done. And then there's our circadian drive for sleep, which is really mostly driven by our exposure to light. So the exposure to light in the morning is very important for decreasing melatonin secretion in the brain and allowing us to be awake during the day. And then in the evening, it's darkness then that leads to the secretion of melatonin by the brain as part of our sleep transition response. So how much sleep do we need? Well, certainly as children, we require a lot more sleep than we do as adults, but our adult sleep requirement is relatively stable. And a lot of people think that we need less sleep as we get older, but that's definitely not true. We often get less sleep because of different health issues that might be affecting our sleep or the amount of time we're actually allowing ourselves to sleep. But our sleep need is very much a part of us, genetically programmed, if you will. So there is certainly this average amount of sleep that people will generally need. Somewhere in this bell curve of 7 to 9 hours is the peak. But there are certainly people who are where the entire family may be what we call short sleepers, or the other extreme where you have entire families that are long sleepers. But I often say to people that, you know, bad sleep is like bad food. More is not necessarily better. So you want to make sure that in addition to getting the appropriate quantity of sleep that is, your individual need for sleep, that the quality of the sleep itself is good. And so one of the most common sleep disruptors is snoring and obstructive sleep apnea. And many people will ask me, what's the difference between snoring and obstructive sleep apnea? And really, they're part of the same picture. They're just kind of a continuation of one to the other. So snoring is really just the sound of the obstruction. But as that obstruction becomes more and more severe, then it starts to lead to drops in oxygen and disruption of the sleep. So they're part of a continuum, and snoring is certainly a sign or an indication that a person could have sleep apnea. So this is a very common problem. It affects 15 to 30 million Americans, it's estimated. It tends to affect men more than women at a ratio of about 2 to 1 until menopause. After menopause, the incidence of sleep apnea in men and women is equal. It is a progressive disorder that can worsen over time. And it's interesting that most people, both men and women, who have sleep apnea that's moderate to severe are even unaware that they have the problem. And it's often a bed partner, someone sharing a hotel room, or perhaps you've had a surgical procedure where the anesthesiologist notes that you have obstruction in your breathing. And this is often how this comes to light. It's amazing that most of us who have sleep apnea are unaware that we even have this problem. So just to give you some definitions here of obstructive sleep apnea, it occurs when our upper airway, which normally we would ideally be breathing through our nose so that the airflow passes through the nose, behind the soft palate, behind the tongue, and into our lungs. But in obstructive sleep apnea, what happens is that the person has tissues that are causing narrowing of the airway. Perhaps the soft palate is a little too long, or the tonsils are large, or the back of the tongue tends to fall back and obstruct the airway. So all of this can cause obstruction in breathing and then lead to potentially drops in oxygen and fragmentation or poor quality sleep. There are a number of health consequences that have been tied to untreated obstructive sleep apnea. Certainly, many studies out there look at the increased risk for stroke, multiple cardiovascular diseases, including coronary artery disease, heart failure, hypertension. Motor vehicle accidents have certainly been tied to untreated obstructive sleep apnea, as well as accidents at work, death, particularly highest in those who have severe obstructive sleep apnea, but also importantly for today's discussion, type 2 diabetes. So obstructive sleep apnea is present in half of patients, at least half of patients with diabetes mellitus. Actually, when I was preparing this talk, I saw some papers that suggested that this number could be much higher, up to 80% of patients with diabetes type 2 having some form of sleep disordered breathing, whether that's simply snoring or more serious forms of sleep apnea. And a third of people with obstructive sleep apnea have diabetes, and that these associations are independent of a common risk factor for both conditions, obesity. So the hallmark of obstructive sleep apnea is that a person, in going from being awake to being asleep, has a decrease in their ability to keep their airway open, and the airway collapses. This leads to drops in oxygen, increases in carbon dioxide, and an increased respiratory effort. This stimulates a sympathetic activation, which is basically our fight or flight response, which leads to increases in heart rate and blood pressure. There's fragmentation of the sleep, restlessness that occurs. There's a compensation by increasing breathing rate and trying to drop that carbon dioxide down and increase our oxygen again. this leads to, again, a fragmentation of the sleep, maybe even a person kind of awakening, gasping. And then the person falls back asleep and the cycle starts again. So this is occurring time and time again throughout the night, sometimes as much as 60, 80 times an hour. So you can imagine how much that would degrade the severity, the quality of a person's sleep. So this is the basis for the connection really between sleep apnea and most other medical conditions. These hallmarks of intermittent drops in oxygen, the fragmentation of the sleep, and this activation of the fight or flight response. Specifically in diabetes, we know that this increased oxidative stress, which results from episodes of drops in oxygen, and the sympathetic activation, which increases the heart rate, blood pressure, and leads to sleep fragmentation, ultimately is the cause of the downstream effects of insulin resistance and high blood sugar that are hallmarks of diabetes mellitus. This is a bidirectional relationship between type 2 diabetes and obstructive sleep apnea, and creates this vicious cycle of worsening of both medical problems, as well as worsening of, for example, weight gain, which is something that can result as sleep apnea becomes worse. And again, this drives a very vicious cycle with regard to making these medical conditions that much harder to control. Cardiovascular disease is also quite common in diabetes and has a lot of overlap as well with obstructive sleep apnea. Again, going back to this fragmentation of sleep, the drops in oxygen, the creation of oxidative stress and inflammation causing the blood vessels to become stickier. And this is sort of this is known to be the basis of, for example, atherosclerosis and heart disease, but also daytime high blood pressure, cardiac arrhythmias, stroke, etc. We know that cardiovascular disease affects about a third of people with diabetes type 2 and is the cause of death in nearly half of patients with type 2 diabetes, primarily from coronary artery disease and stroke. And likewise, 40 to 60% of patients with cardiovascular disease have OSA untreated. So why treat obstructive sleep apnea? Well, if those statistics weren't enough, there was a study that was performed as far back as 1988, where they looked at a group of male patients who had moderate obstructive sleep apnea, and they found if left untreated, these patients, especially the more severe forms of sleep apnea, had a very high risk of death as a result, and that treatment could decrease the risk of death or conversely increase the survival in these patients. So what are some of the signs and symptoms of obstructive sleep apnea? Well, I like to think of them as things that you see at night and things that you see during the day. So at night, many times will be reported to the person that they're snoring very loudly, or that perhaps someone has seen them actually stop breathing, or they may choke or gasp or wake. Drooling is also a sign, awakening with a very dry mouth because the mouth is open. Grinding of the teeth, which is also known as bruxism. Restless sleep, where the person is moving a lot just to try to find a comfortable position which to breathe. Reflux is also, this is what the GERD stands for, also made worse by obstructive sleep apnea, and people will note reflux events during the night, and especially in children, but occasionally in adults, wetting the bed. Daytime symptoms, of course, excessive sleepiness is quite common. Oops, sorry about that. Now I know also how to advance my slides with my pad here. Morning headaches because of the drops in oxygen. Patients will often complain of problems with their concentration, their memory, diminished quality of life, mood disorders such as depression, anxiety, and sexual dysfunction. Sleep apnea is a problem of anatomy, but it isn't just about weight. Only about half of patients with sleep apnea have it because of their weight. Certainly, how we distribute fat in our body plays an important role. For example, we often look at neck circumference as an indication of possible obstructive sleep apnea because this is a representation of the fat pads in the neck. And so a neck circumference of 17 inches in men or 16 inches in women has been correlated with a high incidence of obstructive sleep apnea. Other things we might look for: the size of the person's tonsils, the position of their palate, the size of the tongue relative to the mandible, and the distance between the back of the tongue and the back of the throat. Nasal obstruction can also add to this. As I mentioned earlier, the preferred way to breathe when you are sleeping is through your nose. And if you're unable to breathe through your nose, excuse me, then you're going to have a tendency to open your mouth. And opening your mouth actually allows your tongue to be displaced further back. So ideally, you're breathing well through your nose so that the air can flow back behind the tongue and the soft palate and minimize that obstruction from those areas. We use screening questionnaires to try to identify people with sleep apnea. And I'll mention right now that we're adding this to our website at Albany ENT. So we would certainly welcome you to go onto the website and take the Stop Bang questionnaire. It looks and asks, it's all yes, no questions for snoring. Do you snore loudly? Are you tired during the day or fatigued? Has anybody ever told you that you stopped breathing, or are you choking or gasping awake? Do you have high blood pressure? What is your BMI? Is it greater than 35 kilos per square meter? This is a calculator that you can get online for BMI. And basically, all you need to know is your height and your weight, and it will spit out a number that tells you what that is. Age is a factor here. As I said before, sleep apnea gets worse as we get older. Neck circumference, as I mentioned, and gender. As I mentioned earlier, men are more susceptible than women, except after menopause, then it's equal. So you add up the number of yeses, and basically, if you've added more than five or more, then you're at high risk for obstructive sleep apnea. 3 to 4, intermediate risk, or 0 to 2 would be considered low risk. However, I'd like to point out that if anybody has ever seen you stop breathing, or you've choked or gasped yourself awake, then there's a very high likelihood that you have obstructive sleep apnea. Also, I forgot to mention on the last slide, and one of the purposes of the picture of the family there was that sleep apnea definitely runs in families because we inherit our anatomy. And so if you have close relatives who have obstructive sleep apnea, then your risk for sleep apnea is quite high. This is another quite often used questionnaire that really asks about sleepiness. And this is meant surely only for adults, but it asks about the potential for dozing off to sleep in each of these situations and asks the person to give a numeric value to that. 0, you'd never fall asleep. 1, slight chance. 2, moderate, and 3, high. And basically, it's thought that any number over 10 is significant. I tend to use this much more in my practice to follow patients over time to make sure that we've addressed the sleepiness issue so that they're safer in terms of driving, or that perhaps I have missed another undiagnosed sleep disorder such as narcolepsy, which certainly can coexist with other sleep disorders such as sleep apnea. So how do we test for this? Well, These days, we often use a home sleep apnea test. Patients really prefer this. It's very convenient. They get to sleep in their own bed. Insurers tend to prefer it because it's much less expensive than our gold standard, so to speak, which I'll talk about next. And they're quite reliable these days when they're positive for sleep apnea. They're interpreted by a board certified sleep specialist, such as myself. But the drawback is that they will have a tendency, if anything, to underestimate sleep apnea severity. And the reason they do this is because they don't measure sleep. They measure simply respiratory parameters here. So if the person didn't have a great night's sleep, was awake most of the night because they have this thing attached to them, then it certainly could underestimate the severity of the problem. We don't need to get into this too much, but it also does not measure this type of breathing disorder called respiratory effort-related arousals, which is snoring that basically causes disruption, not just of the bed partner, but of the individual with the problem. And scoring of these type of events requires this type of study, which is the polysomnogram, where we're actually literally measuring the brain waves in order to identify the various stages of sleep the person gets into. And this is quite important, particularly for other types of sleep disorders. But when a person has a home sleep test and that sleep test comes back negative for sleep apnea, then we most often consider getting the PSG study in order to get a more accurate evaluation of the severity of sleep apnea. And as I mentioned, it measures many more things than just the respiratory events. Excuse me for just a moment. OSA severity, we assign a numeric score to. So we talk about the apnea hypopnea index, or the AHI. And basically, these are the number of complete obstructions or partial obstructions, both of which lead to drops in oxygen or fragmentation of the sleep. And so a person can have mild sleep apnea, where they are having 5 to 15 of these events per hour, moderate sleep apnea, where the person is having 15 to 30 events per hour, or over 30 is considered severe sleep apnea. And pediatric scoring is a bit different, so, but we won't be speaking about that today. So who gets treated for obstructive sleep apnea? Well, it's recommended that anyone with an apnea-hypopnea index in the moderate range of greater than 15 events per hour, or moderate to severe range, greater than 15 or greater than 30 events per hour, be treated for obstructive sleep apnea because of all the health consequences of untreated obstructive sleep apnea we talked about earlier. Anyone with an apnea-hypopnea index greater than 5, which would be considered mild obstructive sleep apnea, but has signs and symptoms of excessive sleepiness, or they just feel that their sleep is very non-restorative, or perhaps they're struggling with the drops in oxygen and awakening with morning headaches. Also, patients who have mood disorders or are suffering with insomnia. Insomnia is incredibly common in people who have obstructive sleep apnea because of the disruption that the apneas themselves cause. Anyone with documented hypertension is suggested to treat their even mild sleep apnea, or a history of stroke or ischemic heart disease. And certainly for the purposes of this discussion, in conjunction with the treatment of your type 2 diabetes. And then I always like to mention the fact that sometimes the bed partner is bothered by the person's sleep apnea as well. And so we commonly discuss how one person's sleep disorder can often be two people's sleep problem. But this picture also reminds me that the impact on the quality of life of a person with untreated obstructive sleep apnea can really not be overstated. People with this problem are often quite sleepy during the day and really certainly not living their best lives. They frequently complain of problems at work, at home, in relationships, perhaps sexual dysfunction, and problems with memory, difficulty with learning. And we know that treatment improves all of this. So this is why we emphasize the treatment so strongly. Our gold standard for treatment of obstructive sleep apnea is the use of positive airway pressure. And you may be familiar with the terms of CPAP, which just basically stands for continuous positive airway pressure. So that's giving you air under pressure through a mask interface by a device that just takes room air, pressurizes it, heats it, humidifies it, so it's comfortable for the nose to breathe, and this stents open the airway. This is our gold standard of therapy. The first CPAP was actually a vacuum cleaner in reverse. It was designed by an Australian physician not that long ago in 1980. The positive pressure was delivered through the nose, and they discovered that you could treat obstructive sleep apnea. You could reverse many of the symptoms and signs of sleep apnea, as well as ultimately a lot of science behind the improvement in many of the medical conditions. There have been many advances in positive airway pressure therapy, from the size of the PAP devices. There are now portable devices that basically, if this is your cell phone, that's the size of the portable device. Improvements in the respiratory algorithms, making it easier for the person to breathe with the device. And there are many more options for mask interfaces as well. These mask interfaces can be delivering air through the nose and mouth, or through the nose. As I mentioned earlier, the nose is the preferred way of breathing during sleep. And this increase in mask variety and seal technology and comfort has really moved the technology significantly forward. There's typically a mask for everyone out there. You just have to figure out which one is best for that individual. Monitoring of CPAP therapy has also become very progressed. We use now Bluetooth technology. You can get day-to-day data, information on the effectiveness of your treatment, compliance, through the use of programs on your smartphones. You can get, of course, hours of use if that's required for your job. But as I mentioned before, you can really see the effectiveness of this training. Think of it sort of like the typical Fitbit in that way. So the benefits of treating sleep apnea, just a short summary: better sleep refreshment, feeling better rested, lower risk of heart problems and stroke, reduced risk of mood disorders such as depression, reduced risk of dying from obstructive sleep apnea. Also, quite interesting, reducing the risk of cancer, very common ones such as colorectal, prostate, lung, and breast. And again, this goes back to the whole concept that sleep apnea creates inflammation in the body. And inflammation is the root of much human disease, including cancers. And of course, better management of blood sugar and insulin resistance. So papers have been written on this, that CPAP, the use of continuous positive airway pressure, the treatment of obstructive sleep apnea can improve insulin resistance, and it can also lead to decreases in blood glucose levels, even in the first night of treatment. Think of sleep apnea as a stress, and you may have experienced this in the past, that any stress on the body tends to raise your blood sugar. Well, sleep apnea is absolutely a stress, and CPAP helps to alleviate that. Our biggest problem with CPAP is adherence. And I think this also goes back to the fact that earlier statistic that I gave you, that many people with sleep apnea are not aware that they have the problem. Many people are treating their sleep apnea to satisfy the bed partner who is complaining of their snoring and gasping awake, and the disruption that they're witnessing of the person with the problem but also their own sleep disruption. But CPAP, although highly efficacious, can be a bit of a challenge. And patients will often come in with complaints of, well, it's uncomfortable, it's inconvenient, or perhaps they have problems with claustrophobia, although that we can often overcome. And then sometimes the cost itself of the device, copays, et cetera. So it's quite important when I'm talking to people about this problem to really stress the benefits and to set goals for treatment. In terms of compliance, the most insurers will require that the person is using their device at least 4 hours a night. But really, to get the full benefit of your treatment, you really want to be using this device all night, every night. And certainly, this will give you the most benefit, particularly since I just, again, looking back at an earlier slide where sleep is different over the course of the night. Sleep apnea is always at its worst in REM sleep because that is the stage of sleep where we have the most muscle relaxation. So if you're going to use your CPAP and get the most benefit from it, you really need to cover those times when sleep apnea is at its worst, which would be typically in the early morning. So important to provide that education, encouragement, and you'll find this, there are many wonderful sleep doctors in our community. Thankfully, I'm very fortunate to have such good colleagues with regard to this. But we all try to find the right mask interface for our patients. Again, provide the enhancements such as heated humidification that we feel help to make CPAP therapy more comfortable. There are also other settings such as pressure relief. We work on nasal obstruction because, again, the nose is the preferred way of breathing. So whether that's looking at the allergies in a person's nose or perhaps fixing their deviated septum in an ENT practice, we would have a tendency to look at that. But again, just focusing on this to try to improve adherence. Frequent visits and regular follow-up help us to avoid the frustration and ultimately potential failure of therapy. What are options for people who cannot tolerate CPAP therapy? Well, if weight is the problem, then certainly nutritional counseling or even perhaps consideration for gastric bypass surgery, but keeping in mind that only half of patients have sleep apnea because of their weight. Mandibular advancement devices can be very helpful, and then we'll talk a little bit about surgery. So the mandibular advancement devices are custom-made devices, ideally, that are adjustable, and they have an upper and a lower portion of them. An impression is made of the person's teeth, and then through either side brace technology or front, there's like a little screwdriver type thing here that you can adjust the lower jaw so that you're bringing the lower jaw forward relative to the upper. And this helps to open the airway by bringing the tongue and the soft palate away from the back of the throat. Of course, can't wear one of these if you are edentulous, meaning you've lost all or most of your teeth. And these are best made through a dentist or oral surgeon. But with a prescription from your sleep doctor, many insurances now are providing coverage for the mandibular advancement devices, particularly in CPAP intolerant patients. Talk a bit now about surgeries for sleep apnea, although surgeries are what happens when all else fails, meaning you've exhausted your non-surgical options. Because the one thing I will always say about sleep surgery is that I cannot guarantee a result. No one can. And this is not something that you would do except in the situation where you could not treat this problem in any other way. So these surgeries could be something as simple as, well, I say simple, but believe me, it's not easy getting your tonsils out, particularly as an adult. Tonsillectomy and adenoidectomy. This is something that we particularly do when addressing sleep apnea in children, because they tend to have anatomy where their tonsils are quite enlarged. And so removal of the tonsils often does solve that problem. And then there are other myriad of surgeries as well that can be used to address the various sites of obstruction in the upper airway that may be contributing. We look at the different spaces of the throat. We look at this space behind the soft palate, and we have surgeries that address that. We look at surgeries that address the collapse from behind the tongue, whether it's bringing a bone in the neck forward or bringing the attachment of the tongue forward, or perhaps upper and lower jaw advancement. And then something that I've been, of course, more involved in the past 2.5 years, hypoglossal nerve stimulation. But before we undergo surgery, we often do a procedure called a drug-induced sleep endoscopy. And this is basically a simulation of sleep that is performed in the operating room with general anesthesia, but the person is breathing on their own. And we look with a little scope that we pass through the nose while the person is sleeping to accurately assess the sites of obstruction for surgical planning purposes. So we'll look here at the back of the soft palate and notice how that palate collapses and whether there's a lot of collapse coming from the side walls, or is it coming primarily from the back of the tongue, or is the epiglottis falling back? So again, everybody's anatomy is different and people have different combinations of these things. So this is what makes surgery such a challenge with regard to trying to treat obstructive sleep apnea, is really being able to address the appropriate sites of obstruction or the combination of sites that are obstructing the upper airway. We talk about surgical cure or surgical success. CPAP, I know I can always cure a person of their obstructive sleep apnea as long as they can wear the device and tolerate the air under pressure and the mask interface. But in surgery, we hope to achieve surgical cure, but this only happens about half the time. Surgical success is reduction, of that apnea-hypopnea index by at least half, and bringing the apnea-hypopnea index less than 20. Hypoglossal nerve stimulation, Inspire is the only FDA-approved device. It has 3 main components: a stimulation cuff electrode that goes around the nerve that moves the tongue, a pulse generator that looks a lot like a pacemaker device, and a breathing sensor. This breathing sensor we used to put down here on the lower part of the chest, but now goes just behind the pulse generator. And then the person has a remote, so to speak, that they can turn the device on and off or increase or decrease the amount of stimulation to the tongue. Basically how this works, is we provide mild stimulation to branches of the nerve that move the tongue, the hypoglossal nerve, and we target the muscles that move the tongue forward or stiffen the tongue, and we exclude the branches that stimulate muscles of the tongue that bring the tongue back or bring the tongue down. So you can imagine all the different ways in which our tongue moves. There's one nerve that provides this function, and we try to identify the branches that move the tongue only in a certain way. Okay, nearly done here. So our indications for hypoglossal nerve stimulation, there's an age requirement, there's a BMI requirement. You have to have moderate to severe obstructive sleep apnea in this range. You have to have failed CPAP. And I don't mean you just don't like it. I mean, this is not the same as CPAP. This is for people who literally cannot use that device. And you have to have the appropriate airway anatomy through drug-induced sleep endoscopy. And these are the indications of the implant as approved by the FDA. The implant was first FDA approved in 2014 through the STAR trial. They did follow-up studies out to 5 years and found that the technology maintained its effectiveness without any negative impact on the tongue or the nerves that are being stimulated. The studies looking at the effectiveness of this treatment have generally shown that it has a 90% surgical success, not 100%, and about a 55% surgical cure. My data is very similar to this. And so the comparison of different surgical techniques, you'll see none of these numbers is 100% as CPAP can be, but certainly the more recent technologies of hypoglossal nerve stimulation are doing a much better job than more traditional surgeries had. So in summary, we sleep about 1/3 of our life. Sleep quantity and sleep quality are both quite important. Obstructive sleep apnea is a common problem leading to sleep disruption and multiple health consequences, including diabetes and heart disease. Only half of patients with sleep apnea are obese. So just because you're not doesn't mean that you don't have sleep apnea. That observation of apnea or loud snoring, and certainly taking that stop bang questionnaire could be quite important. And the best treatment for sleep apnea is the use of positive airway pressure therapy. So thank you very much for your attention on this beautiful, beautiful day. And I'm certainly happy to entertain any questions you may have.
Fabulous presentation. There's so much to take in, and I hope everybody was able to take the notes. I'm going to start. There were a load of questions, and I'm not sure as I was listening. We had a question about and you were showing the hypoglossal nerve stimulation device. If you've had a vagus nerve stimulator, can the two work together? Can you have that?
Yes, you can actually have more than one stimulator at a time. You can have spinal cord stims, you can have vagus nerve stimulator, you can have pacemaker, defibrillator. The technologies do coexist quite well.
Wonderful, thank you. Also, there was a question noting that people who have ADHD are sometimes given stimulants that help them calm down, but in others it keeps them awake. What's the reason?
Oh, well, I think, you know, there's a lot we don't quite understand about the way the brain is wired necessarily in those different circumstances. And so, but you'll see often these paradoxical types of, you know, reactions to medications. Same is kind of true. We see that also with, for example, the antihistamines. You know, where some people, antihistamines make them very sleepy. Most adults are like that. But in children and in some adults as well, the antihistamines actually act as a stimulant. You know, why that is, I mean, there's so much we just don't understand about the brain.
Part of the art of medicine.
The art of medicine, yeah.
Another comment and question was, there was a recall from Philips on their CPAPs. Is it a problem that might affect other machines?
So, so far, and I'm sure that this has been certainly under the microscope, but so far there's no reason to think that any of the ResMed or Fisher Paykel, those are two of the other manufacturers of PAP machine devices, primary ones, that there's no reason to think that they have any problems with regard to that. So,
all right. And how quickly can the benefits of a CPAP machine be felt?
Sure. So many people will find that they have sort of an immediate benefit. They might notice that they're dreaming a lot more because they're getting more REM sleep and into deeper stages of sleep. Then there seems to be a little bit of a plateau that occurs, but you'll have to remember too that you know, the brain has been exposed to this intermittent drops in oxygen, and it has definitely been shown that there is hypoxic injury that occurs to the brain as a result of that. And our nervous system, our brains in particular, don't heal the way a cut on the hand or, a surgical wound would heal, which is, right before your very eyes, essentially. It can take, a year or more for the brain to recover from that injury. And that's, again, part of the emphasis I always place on, the importance of treating your sleep apnea all night, every night, because you want to provide that, environment for the best healing of the brain that you can attain.
That's because otherwise it sounds like then it's like if you've got that cut, you're picking at the scab and you don't let it to heal.
Got it.
Yeah. And another participant said noticeable improvement in skin color after one night of using their CPAP. You talked about the appliances. What about mouth guards? Do they help?
So, well, the oral appliances are very similar to a mouth guard, except that a mouth guard is not designed to help move that lower jaw forward. So the mandibular advancement devices are a mouth guard, but they're adjustable. So by pulling the lower jaw forward, you're bringing the tongue away from the back of the throat and opening the airway by bringing the, again, that tongue and palate forward.
Mm-hmm. Somebody noted, they came in a little late. We're glad you came. That's great. Does the T-shirt that makes you sleep on your side work?
Yeah, it can, particularly in patients who have positional sleep apnea. So I certainly have